Welcome. We're glad you're joining us to learn more about obesity and its treatments. Over the next little while, myself and my partners will try to help you understand what this disease is and particularly surgical treatment of it. It's a problem that affects a lot of people, and as we will try to teach you, there are good options for treatment of the disease of obesity. My name is Richard Rasmussen. I'm one of the surgeons in our program. And just to introduce myself a little bit, I grew up in southern Idaho, moved to Orem when I was in high school, and then did my undergraduate at BYU, went up to the University of Utah for my medical school, and did my residency in Phoenix. My interest and expertise is in laparoscopic or minimally invasive surgery. I enjoy doing complex operations through small incisions. And that's where weight loss surgery is these days, and so that's kind of partly why I got into weight loss surgery. For us to really understand the treatment of the disease of obesity, so we really need to understand what the disease is, and we start that off with some definitions. Obesity is typically defined as having a body mass index of 30 or greater. Now, if you're not familiar with body mass index, it's a calculation where you take your height and your weight and you put it into a calculator basically, and it gives you a number. So anything above 30 is considered obese. Bariatrics is the branch of medicine that deals with the treatment of obesity. Now, that can be surgical or medical, and so you'll hear bariatric medicine or bariatric surgery, and that's just referring to the treatment of obesity. Excess weight loss percentage is the way we measure the success of an operation. So we'll show some graphs later on that talk about how much excess weight you can expect to lose. And the way that's calculated is if you have 100 pounds to lose and you lose 70 of those pounds, that's 70% of your excess weight that is lost. And that's how that number is calculated, and that's where those graphs come from. If you look at obesity, it's classified based on those numbers. And so with a BMI greater than 30, it's obese class 1. If it's greater than 35, it's obese class 2 or stage 2. And then if it's greater than 40, it's considered class 3 or stage 3. And then over 65 is stage 4. It used to be referred to just as class, but more recently those names have been changed to stages because it helps us understand better this disease. As the stage gets higher, just like in cancer, then the risk to the individual is higher. The risk of death and other problems is higher as those stages go higher. Now, if you look at these maps, you'll see that from 1990 to 2015, there's been a change in the percentage of the population that's considered obese. So these maps show the percent of the population that has a BMI of 30 or greater, and you can see we'll look at the southeastern states particularly, that where it was maybe 10 to 15% back in 1990, it's now over 35% in some of those states of the population has a BMI of 30 or greater. And you can see the individual states, how they vary. Utah, as a rule, has had a lower percentage of the population with a BMI over 30, but you can see there's been a significant change in Utah as well. So to understand the treatments of the disease, it helps us to understand what causes the disease. This particular slide is meant to indicate that there's lots of different aspects to it. It's a big laundry list of different things that affect obesity. I really like this graphical representation because these are three kind of key areas. There's genetics, there's behavior, and there's our environment. And those three things overlap, and where they overlap is where the expression of this disease is in different individuals. In other words, some people, behavior is going to be more of a component. In other people, genetics is going to be more of a component. But in everybody, there's going to be some aspect of all of these overlapping to create this disease. So why worry about it? Why not just accommodate for it? Well, there's four very important reasons why we should worry about it: death, disease, the cost of it, and then quality of life. So I'm going to address each one of those. If you are a white male, age 20 to 30, and you have a BMI over 45, you will live 13 years less than your normal weight counterparts. If you're a female, that's 8 years less. Now, most of us don't want to die early, so that's a pretty significant statistic. Another set of data that looks at this is if you are a female and you have a BMI of normal, so 22.5 to 25, and we assign your risk of dying as 1, and then we increase your BMI to a BMI of 40 to 45, you have a 2.5 times chance of dying as your normal weight counterparts. In men, that's almost a 3 times chance of dying. So again, risk of dying increases as the BMI increases. Now here's some statistics that show that recently obesity has actually surpassed tobacco as the leading cause of death in the United States. And then you can see how those two compare to so many other causes of death. There can be some debate about these different statistics, but the point is that it is a significant health problem for our nation. Then there are the diseases that are related to obesity. Here are about 20 different diseases that are either exclusively seen in obesity or at least much more represented in the obese population. And I'm going to focus on just one of those, diabetes. The top part of this graphic shows the maps, which is basically the obesity maps that we showed before. Well, if you look at the diabetes maps right below it, you can see that it pretty much just mirrors the obesity map. So as obesity has increased, diabetes has increased as well. Some other statistics: if you have severe obesity, so a BMI over 40, and you are a woman, you have a 93 times higher chance of developing type 2 diabetes. If you're a male, a 42 times chance. So what's the concern about that? Well, it's the complications that come from diabetes: blindness, heart attack and stroke, kidney failure, limb amputations. So all of those things are the result of diabetes that's not controlled. And so while there's good medication to control diabetes, it's even better to not have diabetes because that puts you at even less risk. Another interesting thing is that Harvard estimates that more than 92% of cases of type 2 diabetes could be controlled if we could control obesity. And so the International Diabetes Federation now advocates gastric bypass as a safe and cost-effective way to treat obese patients with type 2 diabetes, and they recommend it earlier on. What about quality of life? Well, depression, low self-esteem, these things seem to come hand in hand with obesity. There may be a biochemical component to that, but regardless, we seem to see them hand in hand. And then just being able to interact in society, going to movies, doing different things, playing with the kids. I'll be honest, one of my favorite aspects of doing this job is when patients come back and they tell me all the things that they can now do with their new lifestyle. I love that aspect. Patients tell me about, they've been skiing first time in 15 years, or other athletic activities, playing with the grandkids, all kinds of different things. Then also there's the cost of treating obesity. This particular graphic talks about direct costs, which are the actual treatment of obesity, and then indirect costs. Those would be things like time off work, or being at work and being not as able to perform tasks. And it's estimated that that is a price tag of $1.42 trillion to our society, so very significant. Then if you look at the personal cost, you can see that it costs for a woman in the U.S. to have obesity almost $5,000 each year. And if you add the value of life lost, that goes up to over $8,000 a year. And then you can see some other statistics. For men, numbers are a little bit different, but similarly, there's a cost to an individual for having this disease. Well, why do we discuss that? Because treatments cost money, right? And so if you think, well, I have no cost before going into a treatment, that's untrue. And it's very interesting that the data shows that with weight loss surgery, that the insurance company, if they're the ones paying for it, they actually, after a few years, actually save money by having paid for the surgery in the savings from the other medical problems that they're not paying for anymore. So pretty significant information. So we're going to shift gears a little bit and talk about some of our thoughts on why this disease exists and so what we do to try to treat it. Now, when we're talking about that, we're talking about our food supply. Our food supply affects our insulin, and if we understand insulin, insulin is what causes fat deposition. It's a hormone in our body that does that. So let's talk a little bit about that. It's a hormone. It comes from the pancreas. Everybody knows about it as far as regulating blood sugar, right? If you're diabetic, you have problems with insulin. It's not regulating your blood sugar. But the part most people don't know or understand about is that it actually causes fat to move, or the components to move into fat cells to have fat cells increase. So if we are in a well-fed state and we have high levels of insulin, we're gonna gain weight. So what we try to do is we try to decrease the amount of insulin that is floating around as a way to try to treat obesity and help people lose weight. So if we understand that it's the insulin that's helping to cause the weight, that if we understand different mechanisms of how we can decrease insulin, that's going to help in our treatment. So let's talk about processed foods. In most processed foods, sugar is the top ingredient, or one of the top ingredients. In fact, it's estimated that of the over 600,000 items in a grocery store, over 80% of those have added sugar. There's also additional additives in them, and the little bit of research that has been done on those additives would suggest that those additives also stimulate the pancreas and they cause insulin secretion, even though they're not affecting blood sugar. There's a concept called the bliss point. So a bliss point this actually started back in the military. They noted that they would supply these healthy, nutritious meals to the soldiers, and they would eat them for a while, but then they would get bored with them, but they would eat white bread all day long. And so it got the interest of some scientists, and they started looking at it, and they found that there were certain ingredients, certain foods that people just would continue eating. Well, unfortunately, that has been used, that concept has been used, and the data behind that by food manufacturers, and so they actually manipulate their recipes or the products that they have to affect this bliss point. So they study this, and because they want you to buy more, right? If we buy more of their products, they do better as a business. Well, the problem is it's hurting us from a health standpoint. Sugar, as I mentioned, is a significant component of this. So when we talk about table sugar, we're talking about sucrose, which is actually made up of glucose and fructose. If we have excess of that, it goes into fat synthesis, and it also can cause addiction. We've learned that it excites the same centers in our brains as do narcotics, heroin, of course, which is an opioid. Those types of things activate centers in our brain, and sugar can activate those same centers. So for some individuals, sugar can become a real chemical addiction. If we look at the glucose part of table sugar, it is the preferred energy for most of the cells of our body. And so it's pulled in and it's broken down, and that's where we get energy from. It's also what's measured in blood sugar. And when there's increased glucose in our blood, the pancreas secretes more insulin. Fructose, which is the other half of table sugar, really has no function in our body. We don't use it for anything, so it just gets broken down. It gets broken down in the liver. What happens, however, if our sugar consumption is too high, then we overwhelm the mechanism that breaks down fructose. And by doing that, it goes into another pathway, and in that other pathway, it's used to produce fat, particular abdominal fat, and that's what creates central obesity. So it's really the beer belly concept, because it is actually that same mechanism in the liver that's being used, and you create the central obesity, or the fat around the abdominal organs, which is felt by most to be the more dangerous type of fat. It's estimated that 100 years ago, the average individual in the United States consumed about 13 pounds of sugar a year. The current estimate is that the average individual consumes about 130 pounds a year. So obviously there's been a significant increase in the amount of sugar we're using. And as mentioned, a lot of that comes in processed foods, because it's added for a preservative, it's added for taste, and so that's where a lot of this comes. So what about different foods? How do they affect our insulin? Well, those that have a minimal effect on insulin would be things like protein, fats, vegetables. They tend to have a pretty small effect on insulin. things that cause a significant increase in insulin would be the carbohydrates. So sugars we've talked about, grains, the more refined, the more their influence on insulin. Basically flour, ground up wheat is basically like sugar. If you look at glycemic index and different measures of the effect that it has on blood sugar, it's basically the same, and actually in some instances probably a little bit worse than sugar. Fruit does tend to push insulin more, but the advantage of fruit is that it has a lot of fiber in it. So if you're eating it as the whole fruit, that fiber is protective. So you don't see quite as much insulin push as you see, for example, if you're just drinking juice. Just some thoughts about how our food supply is part of the problem in this obesity epidemic. And so hopefully that will also help you understand when we talk about post-operatively and we focus a lot on proteins and healthy fats and vegetables, that a lot of the reason behind that is because it's not going to affect those insulin levels as much as the other things. So let's shift a little bit and talk now about treatment options. What are the treatment options? Well, traditionally, diet and exercise, right? There's lots of different options there. Lower the amount that you're consuming and try to exercise more. Well, a couple interesting things about that. Probably the most interesting thing is with exercise, the amount you have to exercise to really make any meaningful impact on your caloric consumption is huge. And so unless you're a professional athlete, you're just probably not doing the amount of exercise that you're going to have any significant effect on that. Diets, there's lots of information around those. For most studies, if you look at the medical literature, for most studies, if you can get about 5 to 10% of your initial weight lost, so if you weigh 300 pounds and you lose 15 to 30 pounds, that's considered success, and it is, because it will decrease your risk of the other diseases. Unfortunately, and for most people, they're just not satisfied with 15 to 30 pounds because they're still heavy and still have a lot of the other limitations, even though there has been some beneficial health benefits. So that's why a lot of people get frustrated with just typical diet and exercise and tend to give up on it. There's also medications for the treatment of obesity. In the last several years, there have been several new medications released. If you look at the results, it's about the same as diet and exercise alone. Most of the studies were approved on about a 5% initial body weight lost result. And then the problem with medications is they have a lot of side effects. So there can be a role for these, but it's not, in my opinion, a primary treatment. You need to be doing, of course, the other things, diet and exercise already, and then maybe add it on top for some help, or occasionally even in post-operative patients who've had surgery, there's a role for using medications in those patients to help give some added benefit. They tend to be expensive, and most of them are not covered by insurance companies. Of the ones we've listed, most of them will run about $200 to $300 a month, and with Saxenda actually being about $1,200 a month. So for most people, following medical or pharmacologic, meaning medication treatments of obesity, just hasn't ended up in the results they want, short-term or long-term. Back in the early 90s, there was a statistic floating around that about 95% of morbidly obese patients who lose a significant amount of weight will regain all of that weight in the following 2 years. I've seen that statistic as low as 80%, but it says that there's a large number of patients who, even though they can be successful initially with medical weight loss, just aren't able to maintain that long term. About that time, gastric bypass had been around in its current form for about 10 years or so, and individuals were seeing that, hey, there's some real success here. And so the National Institutes on Health brought a bunch of experts together, and they had a conference and kind of discussed, the current state of it. And really they were trying to understand, what's the right patient population to have surgical weight loss. And from that meeting came up these recommendations. So if you have a body mass index greater than 40, which is about 100 pounds or more overweight, then you are a candidate for surgical weight loss. if you have a body mass index over 35 and significant weight-related comorbidities, diabetes, high blood pressure, sleep apnea, those types of things, then those are also individuals in whom really what they were saying is the risk of surgery was less than the risk of continuing with the disease. And then they also indicated that patients should have failed a medically supervised weight loss program. And the reason I think they put that in is because there is that small percentage of patients who do well with that. And so if you can do that and you can avoid surgery, then great, that's wonderful. As time has gone on, as we have moved from big open operations to laparoscopic operations, the risk of surgery has dropped down to where now the risk of surgical weight loss is basically the same as any other abdominal operation. Because that risk has decreased, there's also some who advocate decreasing the BMI threshold for those patients who qualify for surgery. So there's a lot of discussion about that, a lot of research being done, particularly in patients who have diabetes. Currently, most insurance companies still follow the recommendations of BMI of 35 with comorbidities or 40 without, but we may see that change in the near future. But who shouldn't have surgery? So who's ineligible for that? Well, if the obesity is caused by some type of metabolic problem, that needs to be controlled first. One great example is hypothyroidism. If your thyroid's out of whack and that's causing you to gain weight, well, of course, that needs to be controlled first. If you have a significant history of substance abuse or major psychiatric disease, weight loss surgery is not easy. Anybody who says it's the easy way out has no concept. They've never met anybody that's been through it. They just have no concept of this process. Most patients, as they go through the process, at some time or other are going to say, oh my goodness, what did I do? You know, this is really tough. Because of that, if you're predisposed to alcohol particularly, or other substance abuse, or other psychiatric problems that aren't controlled, that could basically put you over the edge, and we don't want that to happen. So we'll screen for those things ahead of time, and maybe surgery is not the right answer. Another reason to not have surgery is if you have some medical problem that would preclude you. For example, if your heart is so bad that you can't have major surgery, then of course it doesn't make sense to operate on you. Women who want to become pregnant within the next 18 months, that is not a good time period during that rapid weight loss phase. It's not a good time period to become pregnant. And so if that's your plan, then surgery needs to be delayed, or childbearing needs to be delayed. It's also important to note that with obesity, there's a lot of infertility. And so if you fall in that category, you should use contraception to prevent pregnancy during that time period. If not, you may get pregnant sooner than you want to. And the way that happens is because as you start to lose weight, it changes your fertility, and then you can get pregnant. And we've had that happen to patients. They say, oh, I don't need to worry about it because I've been trying for years, never been able to get pregnant. And then they start losing weight, they become more fertile, and they become pregnant. So those would be reasons. Then in our program, if you are between ages 65 and 70, we take those patients on a case-by-case basis. You need to be a healthy individual in that age range. Also in our program, if patients are between age 65 and 70, we look at that on an individual basis, based on overall health. Additionally, if patients have a BMI over 65, we will require that they get down to a BMI of 65 with medical weight loss before we'll operate, or that may be the patient in whom a duodenal switch will be the right operation. And that will be talked about later about what that operation is. It's not an operation that we offer, but we know some great surgeons who do, and we can refer you there if that's the right operation for you. So after this group got together, made their consensus statement, we had some more direction on which patients should be operated on surgically, and then that's continued to today, where we have lots of data around the effectiveness of these operations in the treatment of obesity. So much so that there are many different organizations who support and advocate weight loss surgery for the treatment of significant obesity. So what are some of the arguments against surgery? Now, these are just things that we've heard from patients, and we just want to help you understand what our feelings are about these arguments, because you may have family members or friends who bring up these arguments. One argument is, I should be able to do this on my own. The reason that's not true is because you are fighting your biology. Once we gain weight, our biology wants us to stay at that heavier weight. So anything we do to try to decrease that weight changes how our body responds. And so the big thing that happens is it drops our basal metabolic rate. And so the large number of calories that we burn just by living and who we are, that drops. And so what that means is we have to consume fewer calories. And for people to do that on a normal sized stomach, that becomes very, very difficult. So that's one reason why a surgical stomach is an advantage, because you have a small stomach, you can eat small amounts, you can be satisfied with that, and that allows you to have a lower caloric consumption to help fight against that drop in basal metabolic rate. Another argument is that it's the easy way out, that it's giving up. Anybody who makes that argument, as I mentioned before, has no real concept of the process. It's not an easy process, it's work. But it's the difference between that and just hardcore diet and exercise is that with the tool and the metabolic changes that happen in the body after surgery, you can actually now have those bigger successes that you want to have, and surgery helps you to do that. Another argument is that it's just cosmetic, it's just for looks. Well, hopefully you've seen from the data I've shared that that's not true. What is true is that this helps you be healthier. It helps you live longer. That's really why we're doing this. And then another argument is I don't want to change my anatomy. I've had one patient say, I don't want to mutilate my body. The biggest problem I have with that argument is that if you had a similar argument, it would be, well, if I have a cancer, I'm not going to let you cut out that cancer because that would be mutilating my body or hurting my body some way. And the reality is we have surgery as an option to treat these medical diseases in very, very effective ways. Yes, it does change the anatomy some, but the results of that are that you can live a longer, healthier life. Hopefully this information has given you some better insight into what obesity is, what some of the treatment thoughts and options are, what causes it, some of those factors. Dr. Watts next is going to talk to you about the surgical treatment options that exist and the advantages and risks involved with those.
Hello, I'm Dr. David Watts. I have been here at Utah Valley Hospital for the last 11 years. I came here with the express intent of starting a bariatric surgery program here, and I loved the association with my fellow surgeons and with the bariatric program and with you as bariatric patients. I grew up in Roy, Utah, a small town suburb of Ogden, Utah, and I went to BYU for my undergraduate, and then I served in the United States Army as a surgeon for 26 years, and that's where I started doing bariatric surgery. I actually did all of my medical and surgical training in the Army, went to the Uniformed Services University of the Health Sciences in Bethesda, Maryland. I did my surgical residency in Hawaii, and I spent the last 14 years of my Army career at Madigan Army Medical Center, and I had the great fortune of being mentored by Dr. Preston Carter, who is really the guru or the mentor to many surgeons in bariatric surgery. During the course of my career, I served in Afghanistan and Iraq and Saudi Arabia, but I really had the privilege of doing weight loss surgery, and now I've been doing that for 24 years. Bariatric surgery is very effective, but it's only a tool in the whole gamut of things that are necessary for you to be successful in weight loss. And we're going to describe why it's such an effective tool. So I'm going to review the digestive system. This may be something that you got in your Health 101 class or high school health class. As you can see, when we eat, our food goes through a long narrow tube called the esophagus, and then our food gets mixed up in the stomach. And I like to think of the stomach like a cement mixer. It moistens and softens the food, but no actual absorption or digestion of food takes place in the stomach. Then the actual rubber meets the road, if you will, in the small intestine. And that's where the actual absorption of nutrients takes place. Both the carbohydrates, proteins, and fats that make up what we call macronutrients, and also minerals and vitamins. And then the digestion is aided by the digestive enzymes that come from the liver, the gallbladder, and the pancreas. Those are all hooked to the small intestine, and then waste is eliminated through the colon. As you can see in this diagram, the liver is a rather large organ, and sometimes in obesity, the liver becomes fatty. And so part of the preoperative preparation for surgery is a 2 to 3 week liquid diet. And the reason for that is to help kickstart weight loss, but most importantly, it's to help shrink down the fatty liver. In obesity, the liver becomes somewhat swollen, and it becomes soft, or what we call friable, meaning that it can tear easily. And so with the liquid diet, that will help shrink the liver down and make surgery safer. There are some trending new surgical weight loss procedures that I'll just go over real briefly. We don't do these at Utah Surgical Weight Loss Center, but these would include things like gastric pacing that helps the stomach to, in essence, feel full faster, which is one of the goals of the surgical weight loss procedures that we do. There's a gastric balloon that probably has the most efficacy in somebody who has to lose a relatively small amount of weight for something like a hip replacement or a knee replacement. It's removable, and so it's not a permanent weight loss solution. Lap bands are something that we don't recommend at this point. Lap bands were one of the more common procedures done in the past, but we have found that there is a high rate of problems with lap bands, such as erosion into the esophagus or the stomach, or food intolerance, and frankly the weight loss is inadequate and not nearly as much as the procedures that we're going to be talking about. So the procedures that we'll mention are the two that we do in our program: sleeve gastrectomy and Roux-Y gastric bypass. And then just in passing again, I'll talk about duodenal switch. The Roux-Y gastric bypass is really the standard, we call it the gold standard procedure for weight loss. That procedure has been done for about 30 years now, so we have really good long-term data. The procedure is done for restriction of gastric content, so that means that a person will feel full much faster with much smaller amounts. And then there's some rerouting of the intestine to get a metabolic benefit. And the chief metabolic benefit is in insulin resistance, or decreasing insulin resistance, which is the main problem, physiologic problem with type 2 diabetes. So when we do a gastric bypass, we create a small gastric pouch. It's literally about the size of my thumb. It's about 6 centimeters long, about 25 millimeters in diameter, and it only holds about 20 milliliters or 20 cc's of fluid. We create this pouch, and then we We divide the small intestine and we bring one limb of the small intestine up to the stomach to create what's called a gastrojejunectomy. And then the two limbs of small bowel in kind of a Y-shaped fashion are joined together so that the digestive juices can join the food stream and digest the food, and then that food is digested downstream. It takes us about 2 hours to do a gastric bypass. It's potentially reversible, but in reality, we consider all bariatric surgery to be a permanent weight loss solution. And so we don't really recommend that patients go into that thinking that at some point they can have that reversed, because unfortunately weight regain happens. You usually stay overnight for 1 night in the hospital, and the usual return to work time is 2 to 3 weeks. The gastric bypass works by restricting the volume that someone can eat before they feel full, and that's really the magic of bariatric surgery, is allowing someone to eat small amounts of food and yet feel full and satisfied. And that's why bariatric surgery tends to be a longer term, more lasting solution for weight loss than any other diet that is out there. There's no macronutrient malabsorption with gastric bypass. So in other words, there's not a malabsorption of carbohydrates, fats, or proteins. There is some challenge with iron, B12, and calcium absorption because the first part of the small intestine is bypassed. But we overcome that with some of the supplementation that we recommend afterwards. One of the unique aspects of a gastric bypass is what's called dumping syndrome. It's very uncomfortable for patients, but it's great negative feedback for patients when they eat something that they shouldn't. And that's mostly something that's very sweet or very calorie dense. And what happens is that a patient starts getting heart palpitations, they get nausea, they may get diarrhea, they really don't feel well. And so this is something that we warn patients about, and if you get it, you don't want to get it again. And so that kind of helps the patient to avoid some of the things that they shouldn't eat. Gastric bypass is a great solution for acid reflux. So people ask why sleeve gastrectomy or gastric bypass, and the short answer is usually that if a patient has diabetes, significant diabetes, or bad acid reflux, generally the gastric bypass is a better solution for them. Otherwise, the sleeve gastrectomy will provide essentially the same amount of weight loss. One of the other differences, and something that we try to be very strict with, is that patients that have had gastric bypasses should not take NSAIDs, non-steroidal anti-inflammatory drugs, such as ibuprofen or naproxen, because of the risk of ulceration. That's higher with a gastric bypass than it is with a sleeve gastrectomy. These are some of the results that we have found with gastric bypass. This is a graph that shows the average excess body weight loss. So if a person's 100 pounds overweight and they lose 75 pounds, they've lost 75% of their excess body weight. And we have found in our program that we can typically achieve around 75% excess body weight loss. And that's for both the sleeve and the gastric bypass. And from this graph, you can see that weight loss is maintained really well over this 4 years of follow-up. Some of the other results of weight loss from either a gastric bypass or a sleeve gastrectomy include resolution of diabetes in a very high percentage of patients. In fact, 82% of patients have complete resolution of their diabetes, and the other 18% have improvement. Hypertension is improved, sleep apnea is improved, osteoarthritis or degenerative joint disease, GERD or gastroesophageal reflux disease or chronic heartburn, that's also improved. Even asthma, which is a disease that's not directly linked to obesity, is often improved with weight loss after bariatric surgery. Dr. Schauer of the Cleveland Clinic stated that bariatric surgery simultaneously treats more disease conditions than any other single medical or surgical treatment. Weight loss from bariatric surgery treats many diseases. We don't propose it as a solution for everything, but GERD, diabetes, hypertension, sleep apnea, and degenerative joint disease are very effectively treated, and sometimes resolved, but certainly improved with weight loss after bariatric surgery. There is some mortality after gastric bypass from the surgery, but the advantage is that there is a significant decrease from all-cause mortality after gastric bypass, and that's been found to be about 40%. And for specific diseases such as coronary artery disease, the decrease in the death rate is 56% for coronary artery disease, of 92% for diabetes, which is really astounding, and 60% for cancers. The death rates do increase slightly for accidents and suicide. Some of the risks of surgery include bleeding and infection, which can happen after any surgery, or heart attack or stroke, or a blood clot in the legs or going to the lungs. There are some specific risks from bariatric surgery. Anemia is something that we watch out for. We will do follow-up labs on patients. Vitamin deficiencies, especially vitamin B12, mineral deficiencies such as calcium, vitamin D deficiency, and there can be failure of weight loss or weight regain. Some of the other specific risks to bariatric surgery would be hernias at some of the incision sites, adhesions, which can happen after any surgery, or conversion to open procedures. But that happens very rarely, and that's usually in patients that have had a lot of surgery, so they have a lot of scarring in their abdomen. Some of the other risks specific to a gastric bypass would be a staple line leak. So there's 3 or 4 different connections or staple lines, and there's a possibility of a leak from those. Distension of the stomach, marginal ulcers. I talked a little bit about that in relationship to avoiding NSAIDs. And then there's a slight risk of obstruction. As we reroute the intestine, we divide the blood supply, or what's called the mesentery. We do close that area, but there is a slight chance that the intestine can slip through that opening. And the overall mortality from gastric bypass is about 2 in 1,000, or 0.2%. Let me talk now about the sleeve gastrectomy. This is the newest operation that we're doing in our surgical weight loss program, and this has become probably the most common bariatric procedure that's done in the United States. It's much more common than the lap band and has taken over the role of lap bands, in my opinion. It's less invasive than a gastric bypass, but it's much more effective than the lap band. And we do the sleeve gastrectomy by creating a narrow tube of stomach. We basically turn the stomach into kind of a banana shape. And we do that by having the anesthesiologist pass an instrument called a bougie, which is a narrow tube that's about that big around. That goes down through the patient's mouth, and we use that as a sizer for the stomach. We start 4 centimeters from the outlet of the stomach, what's called the pylorus, and then we staple off the greater curvature portion of the stomach. So that's the outer portion of the stomach. And we decrease the size of the stomach by about 80%. One of the advantages of a sleeve gastrectomy is it does not change the route of digestion. So the stomach is still the route through which the food goes. The stomach is still connected to the first portion of the intestine called the duodenum, and so there's less risk of iron, calcium, and vitamin B12 malabsorption. It's non-reversible. Once you've removed that section of stomach, the stomach is going to be like that. It takes less time for us to do a sleeve gastrectomy than it does a gastric bypass, about half the time, usually about an hour. Again, you stay in the hospital overnight, and the return to work time is about 1 to 2 weeks. How does the sleeve gastrectomy work? It works similarly to the gastric bypass. It restricts the amount of food that a patient can eat before they feel full. Now, in theory, a person can put more food or fluid in that pouch from a sleeve gastrectomy than they could with a gastric bypass. But in practice, the pressure in that sleeve gastrectomy goes up to the point that a patient feels full at about the same point that they would with the gastric bypass. And I believe that's why the gastric bypass and the sleeve gastrectomy are very similar in their weight loss post-operatively. There is some metabolic benefit from a sleeve gastrectomy, but it's not as immediate as with a gastric bypass. And that's why when patients have significant diabetes, we would recommend that they have a gastric bypass, because there's a change in the sensitivity of the body to insulin very quickly after a gastric bypass, but it takes longer after a sleeve gastrectomy. Some of the risks specific to a sleeve gastrectomy include staple line failure or leak, again, or stricture of the stomach. So the stomach can get too narrow. Oftentimes that can be treated endoscopically by the GI doctors. They can balloon open that stricture. The long-term outcome, as I said, is very similar in terms of weight loss to the gastric bypass. There can be an increase in acid reflux. And again, that's why we advise patients who have significant reflux to have a gastric bypass. And we can talk about that when we consult with you in the office as to what degree of acid reflux would be an indication for gastric bypass over sleeve gastrectomy. And the mortality from this surgery is about half what that is from a gastric bypass, or about 1 in 1,000. The sleeve weight loss you can see with this slide is very similar to a gastric bypass. And again, this is a long-term solution for weight loss. Unlike medical weight loss, where there's a 95% regain of weight within 2 years with gastric bypass or with a sleeve gastrectomy, there is very good long-term weight loss. The duodenal switch is an operation that we have chosen not to do in our program. There are some patients, particularly those that have a BMI of over 60, that may benefit more from a duodenal switch. It tends to be the most invasive of all the procedures. There's more malabsorption issues, requires more supplementation, but sometimes you can achieve up to 90% excess weight loss. This is a graph that shows the long-term trends of the operations done for weight loss in the United States. And you can see down at the bottom that the duodenal switch is done less than 1% of the time. The green curve is sleeve gastrectomy, and you can see that over the last 10 years or so, that has become the most common of the bariatric procedures. Gastric bypass has become a little less common as a percentage, and then the AGB, or the adjustable gastric band, or the lap band, is less than 10% of bariatric procedures at this point. In our program, we try to be very honest and transparent with patients, and we'll advise you as to which operation we think would be the best for you, but we certainly take into account your own preferences for which procedure you would like to have. This is a slide that shows the average weight loss and the cost of the procedure. If you just compare the gastric bypass and the gastric sleeve, in our program, the weight loss is the same. In national studies, the weight loss tends to be a little bit higher for a gastric bypass. I believe that our weight loss is very similar because we ask that patients follow the same diet progression with gastric bypass or with a sleeve gastrectomy. So if you're taking in the same amount of calories as the other patient, your weight loss should be very, very similar. This is a slide that goes over some of the complications that are inherent in some of the bariatric surgical procedures. And you can see from the left-hand side that duodenal switch has a higher complication rate than some of the others because it is more invasive. And so there's a price to be paid for that extra weight loss that you get with a duodenal switch. So we don't really recommend duodenal switch procedures for patients unless they have a very large amount of weight that they need to lose. So again, patients that have a BMI of over 60 would be the ones that we would generally recommend duodenal switch. Gastric bypass and gastric sleeve, the survival rate is very similar, the complication rate is very similar, and we have good long-term data for both of those procedures. Lap band, I've probably said enough about the risks and the decreased efficacy of lap band. I think the most important thing to know about lap band is that no one has ever shown that there's as much weight loss with a lap band as there is with gastric sleeve or with gastric bypass. And with the fairly significant complication rate, we don't feel that the lap band is really worth the effort. The other three on this slide are the newer procedures, and again, we don't really have very much long-term data, and so I would certainly adopt a wait-and-see attitude about these procedures, and there would really only be very limited circumstances where any of these newer procedures would be recommended by us. This is a 10-year weight loss after gastric bypass, so very long-term data. 71.8% of patients will have greater than 20% weight loss, and almost 40% will have over 30% weight loss. This is a slide that shows comparison with matched controls that have not had bariatric surgery, and you can see that with the gastric bypass, that bottom line shows that very few patients don't lose any weight, but there's about half of patients that are in other weight loss programs that will really not lose any weight to speak of. The 12-year data on Roux-Y gastric bypass shows that the weight increase between years 6 and 12 is minimal, and the remission rate of type 2 diabetes at 12 years after the operation was 51%. That's better than any other treatment that is available for diabetes. And that's really what got me into bariatric surgery, was to see diabetic patients that faced the risk of blindness, limb loss, or kidney disease have long-term remission of their diabetes. There's substantial improvement in hypertension and also in lipid levels, which would decrease the risk of cardiac disease. This is kind of the bottom line about bariatric surgery. This is a statement from researchers in surgical weight loss, and they say, unfortunately, lifestyle therapy is generally insufficient as a weight management intervention for patients who are extremely obese. To date, effective long-term weight loss through pharmacological therapy has been marginal, leaving bariatric surgery as the only reported medical intervention providing substantial long-term weight loss for most patients who are severely obese. Why come to us? We're an accredited center by the American Society for Metabolic and Bariatric Surgery. We've had our initial review, and we've had a recertification recently that we passed with flying colors. We follow all the national criteria for safe surgical weight loss. We truly have a committed, caring staff. You will find that as you go through this process that you will love the nurses, the dietitians, the psychologists, our bariatric coordinator, everybody that you'll come into contact. We don't treat you as a number. And I think that we're closer to home for you than you would be if you went someplace else. This is our wall of fame in our office. This shows some of the patients before and after. And one of the things that I love about bariatric surgery, I've always loved that, is when I see a patient a year after their surgery and I don't recognize them because they've changed so much. They've improved their lifestyle, they feel healthier, they're able to do things with their children and their grandchildren that they weren't able to before. And so for me, that's really the satisfaction of bariatric surgery.
My name is John Wintergren. I'm the newest addition to the group. I've been here for 4 years almost, and was born and raised in Logan, Utah. Lived overseas for 4 years in Ecuador and Bangladesh. Went to Logan High School where I graduated and went to Utah State for undergrad. Ultimately ended up going to medical school, University of Colorado. Did residency at Indiana University for 5 years, and then went on to do an additional year of fellowship training at the University of Kentucky in minimally invasive surgery. So the portion I will be reviewing at this point will involve the process after surgery. That primarily involves the dietary changes and process you'll go through immediately after surgery, the various stages of your diet, the medications you'll be taking or won't be taking after surgery, as well as the exercise recommendations that we will propose that, if adhered to, will undoubtedly help you achieve lifelong weight loss changes that will ultimately make you healthier and happier. This is a long process, and it may seem overwhelming, but keep in mind that, from where we start to finish, we will ultimately get you there. So these are kind of the things you need to start preparing to do now. If you're not taking a multivitamin daily, this is something you need to start doing now, including calcium and vitamin D. We will actually check your labs to make sure that the levels in your blood in terms of your vitamins are appropriate, and if any of them are deficient, we will start replacing those currently. We also want to encourage you to keep in mind that one of the most common issues we find with patients having undergone weight loss surgery is dehydration, because taking enough fluid in is very difficult. And so keep in mind that the goal is 64 ounces of water a day, or the quantity of food is not the issue. We want to have you focus on quality and avoid this concept of the Last Supper. The day before surgery, you're thinking, I'm going to have one more last hurrah and make terrible food choices. That's not the way to think of this. Try to keep in mind that we want to have you set up good habits so that when the time comes for surgery, you'll be better prepared to keep these good habits going forward. Again, we're not trying to deprive patients of the joys of life. We realize these are a lot of sacrifices that are difficult to make. They're not easy to make, and they're not going to happen overnight. But we want you to live a healthier life, and we understand that by making some of these choices, you will ultimately be healthier and be able to lose weight, which is ultimately the reason we're trying to do this and help you live a healthier life. And also another simple thing we want you to start considering before surgery is to go for walks. Immediately after surgery, your exercise ability will be limited based on weightlifting restrictions. So if you can at least walk every day, that's something you can start doing now. This is a lifestyle commitment. It's a tool to help you lose weight. There needs to be a commitment, which is a lifelong commitment, which we'll go into a little bit more later, and we've already discussed a little bit, and ultimately on a yearly basis for the rest of your life. Some of the different stages of diets we'll discuss here briefly begin essentially the day of surgery. Day 1 or day 2, we start in what's called a stage 1 diet, which is essentially a liquid diet. It's clear liquids, sugar-free waters, sugar-free other drinks. Again, the whole purpose of this stage is to make sure you can tolerate keeping yourself hydrated and drinking enough water that you don't get dehydrated. That's the number one issue we see immediately post-operatively, is nausea and just the inability to keep yourself hydrated. And so if we can just continue to focus on drinking fluids, and I tell my patients, even if you feel like you're drinking enough fluid and you don't feel thirsty, just keep sipping on a little bit of water or sugar-free liquids throughout the day, because by the time you do feel thirsty, it's too late. Stage 2, typically we will start our patients on stage 2 before they leave the hospital. In rare cases, if patients have some difficulty with the stage 1 diet, we will actually send them home on a stage 1 diet. Or let's say if they make it home on a stage 2 diet, but then have difficulty at home with nausea and being able to keep themselves hydrated, we just go back to stage 1. Again, this stage of the diet will last about 2 weeks. Again, this is basically clear liquids as you had in the hospital, but we add full liquids to this diet. This includes adding dairy products and other protein powder drinks. Again, the focus being primarily diet-laden foods essentially for the rest of your life. You always want to focus on protein and essentially eliminate all unnecessary and essentially all carbohydrates from your diet. Some examples are listed here, including light Greek yogurts, creamy soups, and protein shakes. The goal, again, is to not eat the standard 3 meals a day. That's going to be very difficult to achieve. You want to focus on kind of grazing, essentially, initially, going for 5 to 6 meals a day. Again, the volume that you're going to take in eating-wise, however, is limited. So typically a serving size of 2 ounces by volume, which is about 4 tablespoons, which is not very much. And trust me, once you start doing this, you will actually feel very full after those first couple bites. And again, the whole focus is water, drinking plenty of fluids to keep yourself hydrated. At stage 3 diet, typically we'll start around the week 2 to week 3 range. Again, this is full liquids, but we then begin adding soft foods. These are moist foods, pureed foods, focusing mostly on protein as tolerated. We're trying to decrease the amount of frequency of the diets, the meals you're eating on a daily basis. So initially 5 to 6 times a day. Now you're trying to decrease that down to around 3 to 6 times a day, focusing on low fat, low sugar, or no carbohydrates. Again, the focus always being fluids, 32 to 64 ounces a day is the goal. Here's some examples of the stage 3 diet. Again, soft foods like eggs, deli meat, canned tuna, chicken or cottage cheese, refried beans. And the focus, again, a recommendation during the stage 3 diet, this is where people could have trouble in terms of side effects or dumping syndrome for those who have a gastric bypass. Introduce one food at a time and see how you're able to tolerate it, so that if you do realize that you didn't tolerate that very well, you could try to avoid that, adding that back to your diet and add other foods at a time. So again, just to make sure you're able to tolerate foods as you gradually reintroduce them into your diet. Stage 3 goes on about 4 or 5 weeks. We want you to start adding, again, more proteins, but then at this point adding well-cooked and canned vegetables. And this is very important that ideally these are cooked vegetables, because it's very difficult, in particular with the gastric bypasses with those 2 connections. Those connections can be narrow, and eating raw vegetables or raw fruits essentially for most of your life, but particularly during the immediate post-operative phase with all the swelling and healing that's going on, there's a chance that those things could get held up in those connections and cause a blockage, a temporary blockage of the bowel, which can be very uncomfortable and painful. So it's very important that whenever you chew your food, that you're chewing it extremely well, morsalizing it, make sure you're going very slow, taking small portions, small bites, and again, trying to cook most things so it's easy to digest. We're trying to move away more from the liquid foods at this point, protein shakes. Remember to not drink within 30 minutes of eating and within 30 minutes after finishing eating to avoid the symptoms of dumping. And you're going to take about 20 to 30 minutes to eat your complete meal, which is not very much still. It's going to take you the full 20 to 30 minutes to get that completed. Stage 4 diet is where we start to really add a bunch of the fresh vegetables. And the focus during the diet at this point is 70% protein, 30% vegetables until you reach your desired weight, which we will discuss with you on an individual basis to set that goal. 3 tablespoons of protein and 1 tablespoon of vegetables with a goal of 60 to 75 grams of protein a day. You don't have to force this. This is something that will come gradually, but again, focusing mostly on protein and making sure whatever you eat, again, is very well chewed up. And if I haven't emphasized this already, we'll emphasize it yet again, that fluids is imperative. The most common cause of issues that we have with patients coming back to the hospital or having difficulty with the procedures themselves is dehydration. And so focusing on at least 32 ounces, if not 64 ounces of fluid a day, whether that be water or flavored, non-carbonated, sugar-free drinks is the goal. Remember to avoid carbonated drinks. And again, no calories, avoid caffeinated drinks. Do not drink with meals, 30 minutes before and 30 minutes after, and just sip on fluids all day long. It's important to, at this point, have established a daily routine of taking your vitamins. So that's a multivitamin, calcium supplementation, vitamin D, and sometimes you need other vitamins or minerals such as vitamin B12 or iron that we will, again, check on a regular basis post-operatively. Typically, the first time we'll check it is at your 6-month appointment, then yearly thereafter. But at any point there's a concern, we check your labs and make sure that those levels are appropriate. There are, in some instances, have been reported, in particular with gastric bypass or even in a duodenal switch, that there are irreversible neurologic conditions that can occur from not taking your vitamins. And so it is imperative to make sure you take your vitamins so we can avoid those irreversible consequences. Onto medications. While you're in the hospital, one of our pharmacists will actually go through a detailed review of all of the medications you take and will determine which ones are crushable. And if they are crushable, that's what we will do for the next at least 2 to 3 weeks. If they're not crushable and they're essential, we will try to find a liquid form that you can take for that period of time. In rare cases, we're not able to crush those medications. Depending on the size, we will either make the determination to have you continue taking those medications or hold them temporarily. Again, the concern being that those connections just need time to heal and let the swelling to come down, whether it be a gastric bypass or a sleeve. We just need the swelling to go down. We just don't want to have issues with these pills being taken. For the next at least 3 months in terms of a sleeve, and in lifelong for a gastric bypass, NSAIDs should be avoided if at all possible, or any of their cousins. So drugs like Celebrex and other NSAIDs that are not Tylenol related, such as aspirin also, again, we would like to avoid those to avoid potentially putting you at risk of an ulcer, a bleeding ulcer or perforation at those connections. Hopefully we've developed good lifestyle choices and modifications so that when surgery comes and you're on your process to healing, that these prior temptations are no longer going to be an issue. Focusing on protein, lots of fluid that are not carbonated, that have no carbohydrates, no sweets, and those sorts of things that can make it very difficult for you to lose weight. Fruits and vegetables, which are great for us, and we should take them. Just be very careful, especially with the raw fruits and vegetables such as lettuce or dried fruits, or the skins of fresh fruits. They're difficult to digest. And although, again, I would encourage you to chew them very well, be very careful in eating those kinds of foods because they can be held up in those connections potentially. And again, no alcohol. Dumping syndrome is typically seen in the gastric bypasses. You can see it when patients eat the wrong foods or eat too quickly or too much. It can actually occur almost immediately, or it could be delayed by a certain period of time. Some patients don't have this issue at all. These are the symptoms, which are quite terrible. And if they happen, hopefully they'll encourage you to identify those food choices or those patterns of eating that are not healthy for you so you can make adjustments and avoid those situations in the future. So some of the symptoms include our heart palpitations, sweating, nausea and vomiting, diarrhea, severe abdominal cramping. Sometimes you can get flushed or shaky. And then again, those are just a short list of the symptoms, but typically these are things that you'll notice right immediately after eating. And again, hopefully it'll be a way of gauging what types of foods you should avoid and the way you're eating as well. So the next point we're going to like to focus on is how do we maintain this success? Once we've had you gotten through surgery and you've lost all this weight and you're on your way to recovery now, how do we maintain this for long-term success? The focus, again, in terms of diet maintenance, is high protein and vegetables. A little bit of fat is not bad for us. Fat helps us feel full. It encourages us to eat less. And so again, healthy fats, a small amount, is actually very, very healthy for us. Fruits, again, are kind of a double-edged sword. We love fruits. They have great antioxidants. They're healthy and help protect us from inflammatory states. The problem is they also are full of sugar. And so we want to have a good, healthy balance of fruits to help us get those antioxidants, but to avoid, again, eating so much that we have a higher load of sugar complexes. Again, the focus always being plenty of hydration, 64 ounces of water, and don't forget to take our vitamins and minerals and calcium. Exercise is the other essentially half of this whole process. So the diet and the surgery is one half. The other half is exercise. The goal is 5 to 6 times a day for a minimum of 30 minutes, but ideally an hour a day. Initially, your weight-bearing exercise is going to be limited because we want you to kind of heal from surgery before we really start you pushing a lot of the weightlifting exercises to minimize your risk of a hernia. But once that period comes around, which is typically around 6 weeks after surgery, we want you to start adding weight resistance and some weight-bearing training to your exercise. Again, the whole point of this is just to find something that you'll enjoy doing so you'll actually do it. If you can do that, you'll definitely be successful. As we've kind of emphasized over and over again in this seminar, surgery only resolves the weight health issues, but there's other things that will help patients maintain their success long term. So we have monthly support groups. There's been several studies that show if you're involved in these support groups that your weight loss is greater and actually is maintained longer. That also includes not just losing the weight initially up front, but also preventing you from regaining the weight long term. There are Facebook groups that you can become members of and participate in. We also have additional counseling available if that's necessary. Follow up with us surgeons. Happens very frequently in the first year, and within the first 2 or 3 months, it's almost on an every other week basis. But once we get through that first year of follow-up, we typically go to a yearly follow-up regimen. We again check your labs at 6 months. Again, initially pre-operatively, we'll check your labs, and then again 6 months, and then every year after that. It's been shown repeatedly, time and time again in various studies, that patients who follow up with their surgeon have long-term success and they're happier. Weight loss surgery will not work alone, and we've made that hopefully abundantly clear. It's a tool, it's difficult, it's a challenge, but definitely well worth the challenge. And try to keep that in mind when the times get difficult, and sometimes you're wondering, why am I doing this? That as long as we stick with the program and keep us involved in this process, we can help you get through this and make it a much more easier transition, and ultimately help you live a healthier, happier life with you and your family. So today, I would like you to commit to, again, adhering to a bariatric diet, a healthier, well-balanced diet, to commit to exercising daily, to commit to a lifelong follow-up, which during that first year is very frequent, but then after that first year is on at least an annual basis, to commit to joining 1 or 2 or however many support groups you feel would be appropriate, but at least one support group, to not forget about taking your vitamins and your minerals, which occur on a daily basis, to again develop good dietary changes that will help you avoid regaining your weight and help you achieve your weight loss goals. So again, avoiding carbonation, sugars, caffeine, no tobacco, no alcohol. And again, for women, we advise you to please not consider becoming pregnant within 18 months of surgery. Once we get to the point that we've had the success we've desired and you've lost all this weight, and in some cases, we have excess skin, which can be very problematic. We can deal with this on a case-by-case basis. We typically don't address this for the first at least year, and ideally 2 years, until we get your weight stabilized. But there is options in terms of dealing with that excess weight. It is considered a cosmetic problem, and most times it's not covered by insurance, but this is something we can discuss on a case-by-case basis once we get you through the post-operative phase and get you to your goal weight. So what happens next? We will at some point ask you for your driver's license and insurance cards, primarily to determine what kind of benefits you have with your insurance company, and we will contact you with those options. Once that occurs, we'll have you visit with one of us, the surgeons. We will check your labs, again, go over all the stuff that we've already went through during the seminar. You'll receive some information to help you set up the appointments to have your consultations done with psychiatry, dietary, and physical exercise, and also receive some information on the specific insurance requirements for your particular case. Again, these are the consultations we want you to have: the dietary one, the exercise physiologist, as well as a psychologist or a social worker. This can take time, and so we would ask for your patience during this process. As you understand, this is not something that happens overnight, and in fact, we really don't want it to happen overnight. We want you to have time to develop good modifications in your behavior and in your dietary choices, so that when the time comes to perform surgery, you'll be successful. It can typically take anywhere from 3 to 6 months to go through the insurance process and ultimately be able to submit this for approval, but it does take some time. What you can do now to help speed up this process is start talking to your primary care physician about your weight loss goals, and make sure that when you do have that visit with that person, that they are documenting that the reason you are visiting with them is for weight loss options, because this is one of the criteria necessary for certain insurances to approve bariatric surgery. Be very familiar with the requirements of your particular insurance company so that you can make sure you follow their guidelines. Unfortunately, what can happen is if we, for any reason, deviate from those recommendations, they can make us start all over again, which can be very frustrating sometimes. At some point prior to surgery, you will have a pre-op education. Again, this is after we've had our dietitian, pharmacist, or physical exercise and psychiatrist consultations, but you'll have another preoperative education opportunity to go over in more detailed instruction what surgery will entail in the post-operative expectations. Once we get you scheduled, you'll actually visit with the surgeons yet again to talk about the particular procedure you would ideally undergo based on your particular circumstances and your weight loss goals, and to answer any last-minute questions about those procedures. So in cases where the insurance company will deny approval of your bariatric or weight loss procedure, there is a chance to appeal it. However, it's difficult to appeal these decisions if the bariatric procedure is not included in your policy. There are some resources we have and people you can get in contact with to discuss this should this be an issue. However, in certain cases where insurance is not going to be the primary form of payment, there's a lot of this stuff that we can bypass. The consultations is not bypassable, but in terms of the waiting and the 3 to 6 month wait period, we can kind of streamline that a lot quicker. And so, again, we have here listed a phone number you can call to schedule an appointment sooner to get things going. So, take a deep breath. You've gotten through the whole thing. In summary, we've gone through the whole preoperative process. Hopefully, we've had some understanding of the operative process, the types of surgeries that you'll be able to qualify for, and what's expected post-operatively. Again, this is very daunting, can be very stressful. Many of you are probably thinking, I don't want to do this anymore. And again, this is not an easy process to go through. However, I will assure you that it is doable, that we are here any time of the day to answer questions or concerns. Realize that we as surgeons and as the staff in the weight loss program are going to give our A+ effort. So all that we ask is that you give your A+ effort. And if that occurs, there's no doubt in my mind that everyone who goes through this process in this program will have the success and the weight loss goals that they want to achieve.